All right, great. It is 5 p.m. on the West Coast. Thank you so much for joining us for this webinar this evening. We're going to be talking about practical change through quality improvement. And this webinar is co-sponsored by the Surgeon Performance Program through Setting Scoliosis Straight, as well as the Surgeon Quality Improvement Database through POSNA. Next slide. We have first of all, we'd like to thank Medtronic for sponsoring the SPP program, and it's been tremendous, all the growth that the program has had over the past few years. Next slide. So we have a great panel of speakers. I'm fortunate, I should introduce myself. My name is Salil Upasani. I'm from Rady Children's Hospital, San Diego, and I'm fortunate to co-moderate this webinar with Noelle Larson from the Mayo Clinic. And then we have a great panel of speakers this evening, Pat Cahill from Children's Hospital of Philadelphia, as well as Ron Ruiz from Loma Linda University Health System, Lorena Flacari from Akron Children's, and Anna Rambo from Nemours in Jacksonville. Thank you so much for joining us this evening. Just real quick, some instructions about the webinar. You can submit your questions through the Q&A tab. We will try to hold the questions till the very end because we have a packed agenda. But if we don't answer anything live in the webinar, we'll be sure to respond to you through email or through Marissa. Next slide. So the agenda, I'm just going to be giving a quick introduction about the program. Then Dr. Larson will be talking about SQUID and what data is available for QI studies. Noelle and Dr. Ruiz will also be talking about current QI projects. Then Dr. Cahill will be talking about the importance of device tracking. And then Dr. Flacari and Dr. Rambo will be giving us some real world impact of how these dashboards and registries have been used at their institutions. All right, so I'll take over the screen. Okay, so just a quick introduction about the Surgeon Performance Program. As you know, Setting Scoliosis Straight is the foundation for the HARM study group. The HARM study group started dashboard reporting back in 2011, and the goal of it was to decrease variability amongst surgeons, as well as learn from the best performers and kind of help the entire group get better over time. Dashboard reporting obviously is really important to inform our performance. It provides comparative data with our peers, and it really highlights clinicians that are kind of going above and beyond, or the ones that have areas for improvement. The other huge benefit of this program is that it is supported by the American Board of Orthopedic Surgeons. So you do get SAE, self-assessment credits, and which helps towards your maintenance of certification. So this is actually my 2025 certificate for 10 SAE credits just for contributing patients to this free program. So it's very easy to get involved in SPP. This program is primarily for quality improvement. It is not for research. So there is no PHI that's transmitted at any time. You can get a centralized IRB very easily for your institution, and then you sign a registry participation agreement, and you're able to start enrolling patients into the registry immediately. You can see the growth of this program. SPP started back in 2017, and it just continues to grow exponentially with more than 250 participants in 2026 now. And the number of patients that your performance is compared against is incredible. So you can see that the HARM study group, which has been around for 30 years, has about 10,000 AIS patients. And just within the last 10 years, SPP has collected more than 14,000 patients. And that number just continues to grow. And you can see that there's non-fusion AIS patients, so those undergoing vertebral body tethering, patients undergoing CP neuromuscular surgery, as well as spondylolisthesis. You can see the number of participants in SPP in all the different modules. Clearly, AIS is by far the largest, but there are surgeons contributing patients into all of these categories. And surgeons are really spread all across the country. So we have great representation throughout the US, but also more importantly from out of US locations. And we try to continue to increase our international presence. So what are you getting back from the program? So basically you get these dashboards, and they're created twice a year now. And it gives you comparative practice data to help identify areas of improvement within either your institution or your individual practice. So you can see all the data points that they're reporting, your operating room time, the estimated blood loss, the length of hospitalization, the major COB angle that you're operating on, the percent correction, as well as all of these attributes. So the Linky types, the types of material you're using, as well as rod diameters. Another important component is including complications within 90 days. And since we joined SQUID, we're starting to collect 1 and 2 year post-op follow-up data. The new addition here is the tether dashboards. So we're including all patients undergoing single thoracic or double thoracic or thoracolumbar tethers. We're currently excluding hybrid cases just because of the complexity of the data points that need to be collected, or if there's staged procedures, for example, tether at the, like a selective thoracic fusion first, followed by a tether. But the type of data that you would get from your VBT cases, for example, estimated blood loss by case, you also see where you are within a group of surgeons in terms of your estimated blood loss. And again, the pre and post-operative COB angles, and then how you compare to the group. So first of all, I think it's very interesting to see yourself amongst all of your cases. You can kind of compare your outcomes to yourself, but then you can also compare your outcomes to the entire group. And here's some data on percent correction. So the tether reports are our newest. We only have about 50 surgeons contributing VBT patients. So please start to enter this data if you're already an SPP member, and we'll be presenting your reports soon. The other new thing to report is this neuromuscular dashboard, very similar data points to the AIS that we'd be giving back for all of your CP patients. And then finally, I wanted to highlight these risk-adjusted dashboards. So these are primarily for operating room time, estimated blood loss, and length of hospital stay. And the amazing part here is that we're looking at the complexity of the patients that you're operating on, giving an estimated variable for your particular patients, and then comparing your performance to that risk-adjusted score. So for length of hospital stay, you can see, the expected range for that particular patient based on their complexity. Same thing for estimated blood loss and operating room time. But to be able to get these risk-adjusted scores, it's really important that you appropriately enter all of this particular data into the registry. And then finally, updates to get your mid-year dashboard. The deadline is tomorrow, so hopefully you've been able to enter at least 5 cases. And then also a reminder to keep collecting the 1 and 2 year data that we can add on for SQUID. So none of this would happen without Marissa. Marissa is on the webinar. If you have any questions for her, please reach out, and please use the QR code to sign up. And we look forward to your participation. Next, Noelle Larson is going to be talking to us about SQUID and what data is available to the SQUID participants.
Thank you, Salil. Great to be with you here tonight. And this is really an interesting journey that kind of dates back to when I was serving on the board of POSNA. And we were really looking at registries, and really back in the history of POSNA, like 15 years ago with Lori Carroll, there was a lot of discussion, like, should POSNA be part of a registry, and how do we help patients? So actually, as a group, our board went all the way around and talked to lots of different registries, including the Academy, including commercial entities, and ultimately started this pilot partnership where we could, as POSNA members, could also combine with Surgeon Performance Program and just make sure we're all working together and all rowing in the same direction, and combine our energy and efforts in order to benefit quality and patient care and surgical performance. As you'd imagine, at POSNA, we don't only cover spine, so we had to do a little bit of a pitch, like, why are we only starting with scoliosis to participate in a registry? And we were able actually to generate some data. So this is NSQIP, which is an interesting nurse-derived registry that's at about 200 hospitals around the US. But just looking at the volume of pediatric orthopedic cases, over 20% of pediatric orthopedic cases are actually posterior spine fusions. Number two is elbow fracture pinning. Um, and then, unlike elbow fracture pinning, where there's a very low complication rate, there continues to be quite a high complication rate for both idiopathic and non-idiopathic scoliosis surgery compared to all the other surgeries that we do day in and day out. So we started this partnership, and it was really required a lot of work, both on the part of Harm Study Group and Setting Scoliosis Straight Foundation, as well as various councils under POSNA, and ultimately determined we'd do a 2-year pilot that hopefully will be extended to have POSNA members contribute to the surgeon performance registry and develop, unique dashboards both for idiopathic scoliosis and tether VBT. And since then, we've just seen a lot of success. I mean, there's continued to be a lot of interest in the SQUID or the Surgeon Performance Program, and more members joining both. And again, we're stronger together. We definitely don't want two registries to be formed. We want to have one quality registry together. As you heard from Dr. Upasani, interest primarily in the fusion module, but there are also tether modules available for the POSNA participants. You heard already a little bit also about what's in the dashboard. But I mean, think about this. This was 24,000 AIS fusion patients, and this is actually available for benchmarking. So you saw the dashboards that you can get up to twice per year. They're actually site-specific benchmarks, and if your site or if your chair are interested in this, please reach out to our leadership. You can get a overall report on how your site is comparing to all the other contributing surgeons. In addition, if you want to do a quality project, you can submit a query, and we have Marissa here tonight. But basically, there's a lot of data where you could submit a query for a quality project. Primarily, we have kind of that 90-day outcome right now. We're working towards getting better 1- and 2-year outcome measures. And just in a moment, you'll hear about some of the other quality projects that have been undertaken. But think about visual loss. Think about VTE. I mean, there's a lot of things that you can answer here with 24,000 patients that you may not be able to answer with your own center's data or with something less granular like NSQIP. So I think access to QI projects, both for your own site QI projects to gain resources or attention or improvement at your own site, or national QI projects where you're using the whole registry. Dr. Hedequist has been doing some work with robotics. You already heard again from Dr. Upasani about ABOS, and then also US News and World Report this year had a question asking, do you participate in the scoliosis SQUID or SPP? One note on the data for a QI project, when you get it back, it's not an Excel file. It's more similar to NSQIP or a large registry where the aggregate data is released, but not necessarily the individual patient level data, just for privacy regions and the fact that this is a quality registry. It's not a freestanding research registry. But then thankfully, we have kind of resources through Setting Scoliosis Straight Foundation with a statistician and ability to help you work through that data. So please consider joining. We're going to hear more about this tonight. And with that, I think we'll move forward with our program.
Excellent.
Next, you're going to introduce Dr. Ruiz?
No, go for it. Yeah, Dr. Ruiz is going to be talking about the QI project that he's working on, looking at ICU utilization in neuromuscular and syndromic spinal surgery patients.
Great, thank you. Okay, so as Dr. Upasani had mentioned, we were looking at ICU utilization for neuromuscular scoliosis. So at the Surgeon Performance Program meeting at the SRS meeting in Charlotte, Dr. McIntosh stated there was a need to figure out whether patients with neuromuscular scoliosis undergoing a spinal fusion really needed ICU level of care. She noted at her home institution, ICUs were not necessarily available, and so begged the question of who really needs that level of care. So Brooks et al. With the Harm Study Group in 2019 tried to answer this question with a multi-institutional study But ultimately, all they really concluded was that the protocols at the institution really dictated where patients went, as well as operative time. So that really led us to want to research this more so that we can create some quality improvement programs and see which patients really need to go. Given the complexity of this patient population, we thought that machine learning would be an excellent tool, analytic tool, to analyze patient databases and see if we could decipher which patients and what variables lead to ICU stays. So first, we really wanted to see whether machine learning can do this. So our first move in this quality improvement project was to take data from the SQID database. It's a large database which was readily available for us. We looked at all neuromuscular scoliosis patients that had posterior spinal fusions with pelvic extension from 2016 to 2024, and that resulted in a cohort of 4,015 neuromuscular patients. We divided those patients into a training set for machine learning models as well as a validation set. And we wanted to see, similar to what Brooks et al. Did, whether a brief ICU stay of less than 1 day, which imply that maybe that patient didn't actually need to go to the ICU. We looked at that cohort and ended up with 29% of patients in this SQID data set. But we also wanted to see if we could create a model that looked at patients that really had prolonged ICU stays. And we chose 5 days as the going in the ICU beyond 5 days, given that the national average for neuromuscular stay for a hospital after posterior spinal fusion for neuromuscular scoliosis is about 5 days. And with that, we had about 20% of this cohort. So we looked at the variety of characteristics that were in the NSQIP data set. One of the things that are challenging with these large data sets is missing variables. And to tackle this, we used a missed forest imputation, which essentially this program looked at the data set, tried to find similar patients, and would estimate what the missing data would be. This is pretty accurate up to a threshold of 40%, and so that's the threshold we used. We looked at a large variety of machine learning models. We used decision tree models, which is what Brooks and the Harm Study Group did in 2019, which essentially is, you can think of them as looking at thresholds and dividing patients whether they're above or below. We used tree-based ensembles, which essentially uses a very similar algorithm, but really has optimization for different things, like the cat boost would look at patients with categorical variables and treat those differently compared to others. Neural networks really function similar to the way that we learn a pattern, and we look for nodes and different loose associations rather than purely kind of thresholds. Logistical regression, I think, has been used a lot in research, and the meta ensemble really would combine a lot of these different models and weight them differently. So that's we ran the data through all these different types of algorithms, and we looked for performance. Ultimately, when we were looking at whether patients were staying in the ICU less than 1 day, the XG boost model functioned the best. But you can see under this area under the receiver operator curve, which is well represented here, these models clustered pretty well. They performed pretty similarly. So it really kind of gave us an idea that there was consistency, and it was pretty reassuring. We also looked at how they were doing with essentially guessing wrong with this precision recall curves, and all of them performed above the baseline prevalence line, well above. So again, they were performing well. So then we wanted to see, what are the variables that were important. And for patients who were staying in the ICU for less than 1 day, creatinine ended up being most important. And on the SHAP plot, you can see that high values are in red, low values are in blue. Values to the right imply that they were able to stay for potentially, safe for floor admission, and values on the left, those values, what's called trended toward needing to stay in the ICU. Creatinine was interesting finding, just because we typically think of creatinine as potentially a sign of hydration, but in these neuromuscular patients, they really are a sign of muscle mass and potentially severity of disease. So the higher the creatinine implied that perhaps the severity of disease was lower. Operative times and pretty straightforward, but other factors kind of came through, including sodium. Similarly, we did this for the length of stay for greater than 5 days. Again, you can see in this receiver operator curve that all the models were tightly bound, again, giving some reassurance. Both in the ICU for greater than length of stay of 5 days and for less than 1 day, the area under the curve was about 0.7, which is a fair result. Ideal is 1, but 0.8 is great, and 0.7 is a pretty good result. So with this, we were really able to see that our models were performing well. And again, similarly with this SHAP plot, you can see creatinine is a prominent feature from this data set. So now that we could see that our models were performing well and giving us reasonable results and predictive values, we then wanted to go forward with seeing if we could create something that was clinically useful. So essentially a scoring system or a scorecard. So our first move with this was we reran the data and ran it with an optimization program that created 603 different scoring system variants. So 273 scores for the short ICU stay and 330 for the long ICU stay. And we mapped out which features were really being prominent and influential in both sets. And so, we were looking at, you can see the appearance of creatinine is pretty much influencing most of these models. And so what we found was creatinine, osteotomies, nutritional support, and ventilator status were highly prevalent. So we thought that this was a strong signal that was coming through and that they were a real signal. So then we asked the computer or the machine learning models to take that information. We gave it about 4 to 8 different variables. We asked it to create a total score of 10. And then we allowed it to weight these different variables in different ways. If they were continuous variables like creatinine, we allowed it to create different thresholds. And ultimately, it ran through numerous permutations and created this scoring system with these associated weights, which essentially would give it an accurate score for a teacher learning model. So the teacher learning model went through all the patient data. They knew which ones had gone to the ICU, which ones hadn't, and they gave each patient an assigned score, a percentage of the probability of going to the ICU. And then this algorithm went back and checked if the scorecard would give a similar result. So through these iterations, what we found that a nice balance of sensitivity and negative predictive value was a score greater than 6. And that gave us an area under the curve, again, a validator of machine learning performance of 0.67, which is slightly less than modest, but actually was pretty consistent through 95% of its predictive performance. So it performed well. And again, similarly, when we looked at the extended ICU scorecard, this was the scorecard that was developed with these variables. And again, it's very similar performance. So with this methodology, I think we've created a system that we could potentially move forward with analyzing things like the surgeon performance database and see if we can use large data sets in a meaningful way to create something that's like a clinical tool that will really guide management in the future. But I still think we're a ways off from being there. And that's all I got for you.
Yeah, great job. That's a very stats-heavy analysis. I love it. But I think it'll be interesting to see if we can start applying some of those variables prospectively to, figure out the best patients to go to the ICU. So that's great. Thank you for that.
Thank you.
All right, Noel.
Pause for questions at all? I mean, that was like, wow, what an amazing body of work. And like, that's something you normally start with for like NSQIP, but here we are working with our own data at our own sites, extracted by our own surgeons. I mean, I'd like to have access to that. That's pretty cool.
Yeah. I don't see any questions in Q&A right now. Why don't we keep going just to stay on time, and then if anything comes up, we can get back to those.
Sounds great. Perfect. Here, let me share my screen. So I guess similar to Dr. Ruiz, we started kind of with our own clinical question. And as I started kind of getting my dashboards back, I was just interested in like what a high level of 2 attending surgeries there were. And then also the other trend I was curious about is who's operating with a first assistant who is a nurse practitioner or a PA, and thought I'd dive a little deeper on this question. There's been some previous work on this matter. Baron Lahner looked at the effective training level on first assistant. And then Pat Cahill published a very nice series kind of early in his practice. Lahner's series found higher blood loss if you had a resident as a first assistant, but relatively few number of cases, just 350 surgical procedures at a single center. So we looked at SPP plus harms, that data set that we saw earlier. And basically 26% attending surgeons, 13% nurse practitioner or PAs, and then the remainder resident and fellows. We looked at change over time and did find that maybe there was a slight increase of attendings over time. I don't think this is necessarily publishable, but like this was more for my own interest and understanding, like as a division chair, who do I supply as a first assist for the colleagues that are doing spine surgery. Mid-levels again have been also increasing over time, up to 10% now of cases are done with an APP, nurse practitioner or PA. So how do we compare, right? So looking at patient characteristics, there certainly was a little bit larger curve magnitudes in patients who entered to attending surgery, which makes sense. You might pull out a secondary partner if you have a more complex case. Similarly, longer fusion levels with 2 attending surgery, but also longer operative time. So longest operative time was 2 attending surgery, which is probably potentially from this bias that you're pulling out 2 attendings when you have a more complex AIS case. These are all AIS cases as well. Blood loss was slightly higher in the fellow cohort, and this is unadjusted results. And a big thanks to Alma Sato, who is my research student this year, who is a medical student and will help us prepare some of this data. Looking at mean adjusted difference. So now we're going to adjust for various factors such as Cobb magnitude and adjusting for other preoperative factors, numbers of levels included in the curve. This, with the adjusted difference, again, the longest operative time was 2 attending surgeon. And if we do it with a fellow, it was 22 seconds or 22 minutes shorter. And if we do it with a resident, it was 14 minutes shorter, which was statistically significant. So I think, what does this mean? I think the trends are quite interesting, that more and more so we're using 2 attendings to do AIS surgery. These are still only a mean curve magnitude of less than 60 degrees. Also, more frequently, we're using NP and PAs. Is this something to do with what's available in our society as far as resources, as the residents have shorter work hours and more responsibilities? So it was an interesting data set. Hopefully it's publishable. And I think it could be used actually as a tool if you're a new attending starting somewhere and you want to do 2 attending surgery. You can come out and say, look, 20 to 30% of surgeons around the US are doing 2 attending AIS surgery. But happy to answer questions. And again, this is a tool unlike any others, where you have information about multiple centers, multiple high performance scoliosis sites that you can't necessarily access through NSQIP, similar to what Dr. Ruiz demonstrated.
Yeah, great job. I've seen that data a couple times now, and I've found it really interesting that the best performers were the mid-levels, and I would love to see how to use this data to, figure out how to get more mid-level support at our institution. So, because we're always trying to balance education of the residents and fellows, along with like billing, using the mid-levels in clinics. So any insights or thoughts from either you or Dr. Cahill even about how to get more MPPAs into the OR?
I think that's a nice discussion, actually, showing that there is a role for NPPAs to serve as a first assist, and also I think this shows that not very many people are using like a surgical tech or no first assist. Like it's not
Mhm.
really an option not to have a first assist for AIS surgery, I think,
Mhm.
in 2026. So, and there's fewer residents, so you can't necessarily have a resident in every single case or a fellow in every single case. So I love that point. Maybe I'll rewrite the paper like that. Thanks, Khalil.
No problem. All right, Dr. Kale, you're up.
Great, thanks, Salil. I'm going to talk a little bit about one of the sort of hidden benefits of the surgeon performance registry and the SQUID, which is tracking devices. So, and it dovetails perfectly with some of the stuff that you were talking about, Salil, and that the fact that this is a safety registry. And yes, the number one benefit is that we're improving the episode of care for kids that get scoliosis surgery. But I think we're also, with being able to track devices, we're really raising the entire field, and we're doing things that can help advance our field forward. So, Dr. Larson was talking about some of the data points that are captured in the SQUID registry. Well, also the product name and the make and model, so to speak, are also captured as long as we submit that data. So I'm really going to encourage everybody that's participating to include that data, and I'm going to try to tell you why that's important. So first and foremost, as Dr. Opasny said at the beginning, this is not a research tool. This is a safety registry. And the reason registry started happening within orthopedics is because of the bad experience people had with metal on metal. And certainly we wouldn't want something like that to happen within peds. And if it did, we'd want to be able to catch it sooner than what happened with metal on metal. So since the Academy has not decided to make a pediatric registry, it's really, this is what has come from POSNA to really track our devices. So please include that data and information. But some of the other cool side effects, if you will, or benefits of tracking data is that it can help us with the regulatory processes, which can then lead to making it easier for new implants and devices to get to kids. So these safety registries are sort of a way around some of the difficult parts of getting new devices to kids. So what we heard when we did the Kids Forum that Dr. Larson was at and was run by Callie Todison this year is that we heard from the C-suites of a lot of the implant companies, and they said pediatric populations are just too small to justify putting a lot of resources into making new devices. Product liability is higher in kids, and then the FDA pathways are also just too cumbersome and costly. So this is really preventing industry from engaging in creating new devices and innovations for our patients. So having a safety registry that tracks some of these devices allows industry to go to the FDA and say, hey, we're going to track this stuff after you give it the thumbs up. And in what we've seen recently is that the FDA has allowed for some devices to get approved either fully or conditionally with the understanding that these devices would be tracked very closely once they were released. So one example of that is the tether. So I think this is a model for future devices that I think the FDA realizes kids are not getting devices as quickly, so that they're looking for ways to make it easier on the front end. So some of the things about how the Food and Drug Administration approves devices is that unless it's specifically approved for that indication, you're not allowed to study it prospectively. So if you're using an adult device for your patients, you can't do a prospective study on that device. However, the FDA does allow us to capture device information if we're capturing information as part of a safety registry, and that's exactly what we're talking about today. And then once that device is captured, that data can then be amalgamated and used for submission to the FDA as part of regulatory processes. So in lieu of being able to do prospective studies that are sponsored by industry and very costly, we can capture device data and use that to help the FDA understand how these products are working. And the FDA has this mandate to look at data in the real world, not just do prospective randomized FDA-approved trials. They are also not just allowed to, but encouraged to use what's called real-world data. And that's data that's not gathered specifically as a clinical trial for regulatory purposes. So one great example of how our registry is really good at collecting real world data. So the harm study group decided to do a study, and they did a retrospective study on the Mountaineer, which is a posterior cervical system that was approved for adults but not kids. And they just had some of their sites, a very small study, just kind of report all the cases that they had used with this. And the FDA recognizes that this data structure that's being used for the SQUID through the Setting Scoliosis Straight Foundation is very high quality data. And the outcome of this study is that we were able to generate a safety profile for these Mountaineer implants. This is a specific company. I don't have any relationship with this company, but that company could then take this data and approach the FDA to try to get approval. And I think that's forthcoming pretty soon because of this relatively modest study. And potentially we could have some of the same advancements for our kids. And now that device can be studied prospectively, or if it was a bad device, we would have that information and have that understanding. And really, if we don't do some of this work for device development for kids, clearly industry will not. They've told us that to our faces that this is a money losing proposition to try to innovate in this area. And the FDA has generated their own data on this. When they look at the number of new devices that they've approved for adults in yellow versus kids, or even just the number of applications for approval, it's diverging. And this data, they've updated this data relatively recently and shown that the slopes of these lines have continued in the same trajectory. So I think it's incumbent on us to try to do some things to make these regulatory processes a little bit easier, and tracking our devices is a really low-hanging fruit to help make it easier and more enticing for innovators and industry to look at pediatric populations for their work. Thank you very much.
Yeah, nice job, Pat. I had a quick question for you. So when FDA is looking at, say QI collected data for VBT, what are they using as like either gold standard? Because they can't be comparing it to posterior fusion. Is it more about, how all the different surgeons are reporting outcomes, or?
Yeah, first and foremost, the FDA is looking at safety and efficacy. So they're going to be looking at really severe complications and adverse events that are associated with any of these things. And I'm not really sure what their control groups are when they pull real world data. And so unless that stuff is presented as part of a paper, they probably use historic controls from AIS, posterior spinal fusion data sets. But I don't know. And certainly real world data can't be the only data that's part of a process to get a device approved. But we've seen, including the approval for pedicle screws that came from data from the Setting Scoliosis Straight Foundation, just an overwhelming number of cases and track record of using these devices is very compelling in terms of letting the FDA say, yeah, this is what's going on, and it's clearly safe because people are using it everywhere, and we're having consistent outcomes.
Yeah, that's great.
I'd just add too, like at our kids forum in POSNA, it was just amazing how much industry was actually reading our articles. Like they're actively reading our articles and scouring them for what type of device has been used and whether the existing articles and existing data can be used, to try to get these necessary approvals. So, because without a pediatric approval, the company can't educate surgeons on it. They can't develop smaller devices designated for children. And really, most importantly, there's no ability to do research on it. So anyway, thank you, Pat. That was just amazing.
Yeah.
Oh, awesome. Thanks.
Great. So next we have Dr. Filkari talking to us about the real world impact of these registries at Akron.
Yeah, thank you so much for having me. I just wanted to give a couple pearls that we have kind of learned in this process of joining SQUID and contributing data and participating in the dashboard. So really kind of two major ways that we have found benefit to this registry. So number one, we created all these EPIC and EMR tools for data extraction. And that process alone had a lot of downstream effects, not just the good data, but it improved our clinical efficiency and standardization. And then also participation in the dashboard has been just an amazing way to get data on just benchmark data, how we compare, and that has been a driver of quality improvement. So There was a prior webinar that was great that Scottish Rite led, Brandon Ramo, and we have modeled a lot of their tools for creating smart elements to pull data. So we created these specifically to capture, track, and export data to Excel, which goes into a template that goes directly into SPP SQUID. And I have found that these are also greatly useful just in a busy clinic at improving efficiency. Same thing for a surgical smart form. We can generate these discrete data points that get exported directly into SPP and SQUID that just gives you an amazing amount of data. You can generate an op node at the click of a finger. And then that also kind of forced our groups to develop standardization. We agreed on norms when we were creating these tools, which we became way more standardized than we ever had in terms of implant selection, correction techniques, even simple things like closure, which our OR staff is greatly appreciative about, and I do think has led to better efficiency as well as cost savings. So the time up front for this Epic build has definitely paid off. It not just in terms of the data that we're able to contribute to SPP, but also the internal process improvement that this whole process has driven in terms of efficiency and standardization. Then also the dashboard. So we're a freestanding children's hospital, as a lot of POSNA members are. So we're very grateful for the opportunity to have external benchmark data, just to see where we are and how we stack up and what our outcomes really are. So this was my dashboard this year, and I was really shocked to see this. I thought my patient population was fairly normal, and I am like a far right outlier with a heavy patient population. So this was really surprising to me, and I never would have even realized this without this SPP dashboard. So I kind of dug into the details a little bit, and I really think that it's because my primary population is an underserved outreach clinic. I was asking my partners, like, does your data look like this? And theirs definitely does not. So, as a result of this data that I received through SPP, I've started this huge collaboration with our Healthy Active Living Center, addressing obesity, most notable in our underserved orthopedic populations. And this is not really just for my surgical patients, it's really all patients that we're seeing who are obese. We're getting better guidelines and pathways for management and nutrition guidance and handouts. And so this has been a really big internal project directly resulting from my SPP dashboard. And then just validation of outcomes, looking at where we are, where we stand. And so there are surprising things that you can discover when you look into the data. So I have a fast op time, but my EBL is in the third quartile. So those didn't really match up. So what is the purpose of being fast if you're losing more blood? So, and this was very similar to our NSQIP data too. So recently, this really prompted a huge kind of revamping of our blood loss pathway. So, crossing with best practice guidelines and just looking at opportunities to improve our blood loss, not just in big neuromuscular cases, but all cases. So, hopefully, we'll see this reflected in our future dashboards. And then finally, just the impact of the data. So this is such an amazing opportunity to leverage large scale multi-center data for QI projects. So there are so many variables, as we've seen tonight, that are just readily available for quality improvement projects. You just click this link. There's a form. It's very simple to fill out with what data that you're looking at. So I submitted a question this year of using national benchmark data. How do risk-adjusted outcomes differ among the actual surgeon participants? I wanted to look at surgeon demographics, surgeon experience, spine volume, both from the surgeon as well as the institution, and then also practice type, academic, children's hospital, hospital network, or private practice. And I wanted to look at outcomes, length of stay, blood loss, complications, PROMs, radiographic outcomes. Unfortunately, I was not able to complete this request as this data is not currently available. It's not in the dashboard. But I do think it's really important that we look at this. So this is my plea to everyone on here tonight to please fill out this survey. It has been sent out previously, and we'll try again to get better response rate. I think we're at about 20% response rate. So I would love to raise those numbers up and help answer this question. So we definitely have noticed multiple ways that SQUID and SPP has already improved the quality of care we provide. From a quality improvement standpoint, surgical standardization, efficiency, data management, and then really evaluation of our outcomes. So we're very grateful to be participating, and we're excited of what we can do with this data. So thank you.
Excellent
terrific.
presentation. Yeah, thank you so much. Those two, so your survey and the QI form will definitely send out with the post webinar surveys that we send. So hopefully we can get more respondents for you and kind of answer that QI project that you're looking for. I had a quick question for you about your BMI population. Are there other groups within your institution that you're partnering with, like maybe your endocrinologists or nutritionists or something to help optimize weight?
Yeah,
in
so
patients now?
we have this healthy active living clinic, and it is a multidisciplinary clinic. So an endocrinologist is a member, a nutritionist or dietitian, a psychologist, a pediatrician is the one that's kind of guiding it. So it's a really pretty amazing resource, and I had never initiated contact with them prior to this dashboard. So I think that there's a lot of things we can do with this that will not just improve our surgical outcomes, but just the health outcomes long term of our patient population. So, so I think there's probably a lot of work that is still yet to be done.
Yeah. And I also wanted to congratulate you on getting through that epic quagmire, because we're still stuck in it like a year and a half later. So any tips and tricks for people on how to incorporate some of Brandon's great, smart forms and everything?
Yeah, the best tip I can give you is to reach out to Scottish Rite and have their Epic people talk to your Epic people. That was the best thing I ever did.
Yeah.
And they really kind of copied a lot of the tools that they had. And then once we became more familiar with these smart forms, I found so many other uses for them. I use them all the time in different ways. So I think it's a really powerful tool. And so kind of once you get your foot in the door, you can just kind of keep building on that.
Yeah, perfect. All right. So next we have Anna Rambo. Dr. Rambo's coming to us from Jacksonville, Florida, talking about the real world impact at her institution.
Can you see my screen?
Yes, perfect. Thank you.
Perfect. I'd like to thank SPP for giving me the opportunity to be involved with this webinar. My name is Anna Rambo. I'm in Jacksonville, Florida, and it's been really interesting learning how SPP has really made a lot of downstream effects at different surgeons' hospitals. And I'm very interested in integrating the Epic. I've heard about it, but we're currently manually entering everything. So I'd love to make things more efficient. But just a little background with me, I'm in my 5th year of practice. I was extremely lucky to get a job at Nemours in Jacksonville, Florida, post-COVID, super busy, healthy population, close to the beach, close to Georgia. Also very lucky to have 2 partners with a lot more experience than me and a database that was already present. So we have a database that includes all the SPP metrics, but also some additional institutional specific metrics, and we just enter everything manually into our database. So that sometimes is a little painful, but I'm super fortunate that was all in position and set up when I joined the practice. So just going to share a little bit of my personal data and how SPP has really helped me improve as a surgeon. And hopefully it can help someone else. And if you're not participating in SPP, I would definitely encourage you too. So my very first dashboard I received for 2022 was for 13 patients. So I started practice in the fall of 2021, first case in the spring of 2022. And not surprising, I found out that I was very slow. So in the 4th quartile, no complications, but very slow. This was not surprising. I also found out I lost a lot more blood than I realized I did. I thought maybe going slower would help with blood loss. but it did not. So this was very humbling just to get this raw data, and actually compared myself to my two partners to using our database. It was very similar. And then encouraging was that very much like a young surgeon starting out, blood loss is higher and I was slower, but my deformity correction was pretty on par with everyone else and that participated in SPP. So that was very encouraging for me. So I made it my mission over the next few years to really help try to improve this trend of having a lot more blood loss than my peers and also being a little bit slower. So over the past few years, I really tried to learn from my partners, be really vigilant about blood loss, encourage the residents to participate in the case, but maybe don't let them be as involved in the dissection. So this was kind of my personal mission over the past few years. And then once this got a little better, then I started focusing things on increasing kyphosis and on other metrics, but just the dashboard from 2022 to 2025, I'm still slow, but now in the third quartile, so slightly quicker, but still no major complications or intraoperative neuromonitoring events that had any long-lasting effects. But my blood loss improved significantly, so this is extremely encouraging data to see, and deformity correction is still about the same. But I was really like to see this trend that the EBL is decreasing, even though I'm still a little slow. But I think if I'm a little slow and the blood loss is better, then that's really good for the patient and for quality care. So I've really enjoyed participating in this. I think that it's really important to be involved in a registry and to evaluate how you're doing. You might be thinking that you're doing an amazing job, or maybe that you're not doing a great job, but you really don't know until you have the raw objective data sitting in front of you. So I've really enjoyed being a part of SPP. And now that I've kind of gotten used to it and gotten my feet wet, hoping to do some more projects like some of the other speakers have talked about. But thank you for letting me participate.
Yeah, great presentation. Thank you for sharing your experience. What types of things do you think you changed in terms of minimizing blood loss?
So one thing which doesn't happen intraoperatively, but postoperatively, I was using a drain. So I stopped using a drain and haven't had a blood transfusion in, I think, 3 years now in an AIS case. And beforehand, I always used bone scalpel, used the Aquamantis, but I think really decreasing the amount of tearing or pulling on the tissue. One of my partners, Kevin Neal, has extremely low blood loss. So I scrubbed a couple cases with him, tried to watch how he dissects. And really, even though he's very quickly, he spends his time dissecting. And every time I bring the O-arm in, I'll pack the upper or lower part of the spine with epi-soaked sponges and the part that's not going to be taken into the image, and just anything I can do to help minimize blood loss. But I think it's just paying attention to it too.
Yeah, that's great. I think a lot of our studies kind of walk that fine line between QI and research. And I think like your experience is perfect for QI. And I would like really encourage you to write up that experience if you're interested. And of course, like all of us would be happy to help you with that project. But since you're interested in starting up a new project, I think you've already completed one, and it's just a matter of publishing that experience. So that's fantastic. Thank you so much for sharing that.
Yeah, if we all fill out the survey, then we could do, analysis on, what year in practice, and even do trend lines, how over time we all improve over time. And this is a natural expected course. So thank you so much, Dr. Rambo, for being brave enough to share that. And we know your patients are in great hands, particularly with a surgeon like that who will, take initiative and learn from her partners and improve over time. So this is the kind of case scenario that this whole registry was designed to support.
Great. So no other questions right now. Anything from the speakers for each other, or anything we can address before the closing slides? I think we're right on time.
It looks like somebody has their hand raised.
Oh,
One of the attendees.
wow, I cannot see that.
Oh, now
Please
it's
feel
down.
free.
Yeah.
Oh, Pat,
Th-
go ahead.
I wasn't the one that had my hand raised, but I have a question for the panelists. It's cool to hear from Dr. Flaccari and Dr. Rambo about how they changed their own practice, but I wonder if anybody on the panel has like shared their individual data with their teams in the OR and said, "Hey, remember when we started using blah blah blah? Well, this is what like," and kind of made it like a group win for the intraoperative team. Has anybody done that?
Yeah, that's a great idea. I have not done that. But I think the steps that we're taking is, for institutions, like within a group of 4 or 5 spine surgeons, making it like an institutional initiative. But I think what you're saying, in terms of taking it into your OR team as well, I think that's a great way to get everyone moving in the same direction and kind of working to improve outcomes. So that's a great idea.
I will
Or
definitely also pursue having like an institutional rating, which you mentioned at the beginning of this. I think that would be a great thing to share with the entire team. So it's like not just I'm sharing my own data, but kind of like
Yeah.
how we're doing as a group, I think would be really great to have.
Yeah, I worry that it might get into, the US news world, and I don't necessarily want to make this like a competition between institutions, but again, there's places where we can learn from, you know, people who are doing it really well and kind of spread those best practices. So it's just a matter of kind of keeping it in this realm of improving outcomes and improving patient care. So, yeah. Thoughts, Dr. Larson?
Oh, I was just going to say a big thank you to everyone who's contributing data. I think we're all working hard to make the data entry more facile and more fun. If you have ideas about how these groups could work, I mean, we're on an evolutionary pathway here of surgeon performance. So please give us feedback. We want this to be a community, not just a registry, and all get better together. There's a final few slides here about how to get started if you're interested. Please spread the word. And really, this is not just to benefit my patients or your patients, but patients as a whole around the world who have to go through these surgeries. So thanks, everybody. Thanks also to Medtronic. Medtronic has sponsored the Surgeon Performance Program for years. So if you're doing this work, feel free to engage your local Medtronic person, or if you're at a national meeting, this is something we'd like to continue to have funded and not have to charge subscription fees. So, and then big thanks to Marissa and to all of Setting Scoliosis Straight Foundation. Marissa does this nearly full time. So thank you for running this really powerful registry that's going to help patients have more successful outcomes. All right. Have a great night, everybody. Thanks, Dr. Upasani. Thanks to
Yeah,
all
no
our
problem. Thank
speakers.
you. Thank you,
Yeah.
everyone. Have a
Thank
great
you.
night.
Okay.
Bye.
Thanks.